I think we're finally getting to a point where we can call precision medicine precise, right? It was kind of a nice little buzzword. But now you're seeing very specific uses for the genetic risk, and you're giving patients a very clear path to go down in some cases. We really want to make the whole public aware that this technology is available, and it's not millions of dollars. It's not thousands of dollars. It's accessible. And our job now is to educate the doctors, make them understand the science behind it and why it's valid, help them understand the utility and what you could do with it, and do the same with patients. And I think we're in a day and age where the patients are going to run faster than a lot of the providers.
Hi, everybody, and welcome back to What's Next? Stories of Industry Reinvention by TechNexus Venture Collaborative. I'm your host, Jim Dallke, TechNexus's Director of Communications, and I'm thrilled to welcome our guest today, Jason Lobel, the co-founder and CEO of GenomicMD, a company doing something genuinely important, bridging the gap between genomic science and everyday clinical care. We've known for years that your DNA holds critical clues about your health, your risk for certain cancers, how your body processes medications, whether a specific treatment is likely to work for you. The science has been there. The problem is that for most patients and even most physicians, that information has stayed locked away in research labs, specialty clinics, or the fine print of a consumer test you took years ago and forgot about. GenomicMD is changing that. The company has built a platform that puts genomic insights directly into clinical workflows, giving physicians the tools they need to act on this data in real time at the point of care. Think of it as the infrastructure layer that makes genomic medicine something your doctor can actually use today, not just in a clinical trial 10 years from now. Jason, welcome to the program. Great to have you here. Before we get into the company and everything you guys are building, tell us a little bit about your background and how you kind of ended up here at this intersection of medicine and technology.
Thank you, Jim. Glad to be here and appreciate inviting me on the show today. So I took a quite the non-traditional path to genomics. I started my career as an investment banker, worked at a hedge fund for about a decade, selling companies, raising money, doing that grind. And in 2013, I started an AI and analytics company called Swift IQ, before AI was so cool and top of mind. That company collected billions of records of transaction level data from large retailers and automated an analytical workflow to help consumer packaged goods companies like Coca-Cola, Pepsi, Anheuser-Busch optimize promotion, inventory pricing, all the way down to per item per store across thousands of stores. So we raised venture money. We sold that company January 2020, weeks before COVID, fortuitously, to a company called PDI Technologies, which is a leader in ERP platforms for convenience retail. And after I sold that company, I had just some really awful things come into my space. My very good friend and lawyer of 15 years, his wife died of metastatic breast cancer at 50. And she was the co-chair of Lynch Sage, which is actually Northwestern's breast cancer foundation. So she had tremendous amount of resources and had cancer 10 years prior, and it came back. And by that time, it had spread everywhere, and it was a really tragic situation. And then I had an advisor of mine, Marshall Gibbs, who passed of a pulmonary embolism also at 50. And so just seeing these two young friends of mine go through that, this is obviously in COVID, I had a lot of time on my hands. I started doing my research, and I was a finance investment banking major. So I didn't take a lot of science classes in college. So I was starting pretty much from ground zero. And I I live in downtown Chicago, and I had a friend who connected me with the precision medicine team at Endeavor Health. And I met with Dr. Jinfeng Xu, who runs translational research at Endeavor. And I had an idea for a company, and he told me flat out pretty quickly that it was a pretty terrible idea, and it was decade away plus from being in the clinic, not enough research. And I kind of, was a little disgruntled. And he asked me, he said, I've been working on something for about 20 years and I think it's ready for the clinic. And I said, oh, yeah, what's that? And he educated me on this whole concept of polygenic risk scores. And he showed me one Venn diagram that changed, where I am today. And the research publication was called something like "It Takes Three to Do It Right," genetic research, inherited prostate cancer. And it said, less than 2% of men have a rare pathogenic mutation, HOXB13, a BRCA mutation that causes, significant lifetime risk of prostate cancer. And about 7% of men have a first-degree family history of prostate cancer. And he can predict 19% of those at risk for prostate cancer by analyzing hundreds of thousands or millions of small impact common variants, common meaning they're in over 5% of the population. And he's looking at all these variants, many of them that are in between the genes, right, that are in a non-protein coding region in your body. So we don't generally know exactly what each one does, and they're very small impact, and some are productive. And I was like, 10-to-1 benefit. You can predict 10 times the status quo by analyzing all this other stuff in the, quote, dark genome. And he said, absolutely. And then, he educated me that this is consistent across cancers, and a lot of conditions like type 2 diabetes don't have the ability to predict a lot of the population at risk through a single gene or monogenic mutation. And diseases like coronary artery disease, largest killer of Americans, is not something that's traditionally a monogenic, cause, right? 1 in 250 people have a gene variant related to familial hypercholesterolemia. But you can predict, over 12% by looking at all these small impact variants. So I was fascinated by the science. We were supposed to meet for 30 minutes. We met, I think, for 3 hours that day on a rainy, it was in October of 21. And I said, wow, this looks really interesting. 10-to-1. I started to just pour myself into the research, and was certainly bugging him frequently to, what does this mean? What does that mean? What does this mean? Right? Because I wasn't a geneticist. And so I called the first investor in my first company, Swift IQ. And I said, hey, you want to do another one? And he gave us a commitment for $750,000 to build out the R&D and to test this. And I had started with my two co-founders who I had actually worked with at my first company, Song Gao and Mihao Filipchak. And we'd been working together, for over 7 years. They were early hires at my first startup. And one ran engineering, one ran product. And I said, you want to try to build something with me? This is going to be complicated. And I think we have this industry pioneer that might be willing to give us a little bit of feedback. So we started to build, and we went to Endeavor and said, hey, I would love to partner with you. If we were able to fund, a research grant, would you be willing to work with us? And they're like, who on earth are you guys? Get out of here. Like, we're already doing this. We're one of the top precision medicine hospitals in the country. And so we said, okay, we're going to build this anyway. Nobody's doing it yet. It's not in the clinical guidelines. There's not a lot of reimbursement coverage for this kind of stuff. So we started building. We formed a CLIA grade lab. It's virtual. So we partnered with other wet labs so we could scale and not invest CapEx in the physical lab, but invest everything in the algorithms and the user experience. And we were off and running. And about 9 months later, Endeavor called us and said, hey, we know you've been building this. do you want to participate in an RFP? We actually want to be the first hospital system in the US to put this in the clinic. And we're like, okay, RFP usually is not a good sign for a startup. Um, and we put our best foot forward, and we were notified we won the RFP. So that was just a huge milestone back in March of 2023. And it took a while. Endeavor, or at the time, that was North Shore University Health System. They were merging with Edward Elmhurst, NCH, Swedish. So there was this amalgamation of hospitals coming together in Chicago. And so we had to wait about 9 months before we could negotiate that. And we went live January 2024, the first clinical grade lab to put a polygenic risk score risk assessment into the clinic.
Mm,
So that was really
mm,
exciting to
mm.
be kind of the first to do this
Y-
with a major pioneering health system.
Yeah. 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 I mean, what a founding story. I mean, obviously so many great businesses start with something that affects the founder personally and especially in the healthcare space, right? And so
Mhm.
clearly you can see the mission that you guys have that they are working behind here. Let's talk a little bit about how genomic works specifically. Walk us through the process, from the hospital to the patient. Explain a little bit about the ins and outs of how genomic works.
Absolutely. So it's a clinical grade test, which means we need a physician order. We are not selling direct online. This is a clinical grade platform. It's regulated. So either a doctor can either order our test through their EHR, or they can register at our provider.genomicmd.com. And there's some criteria that would make our screening eligible for insurance. So if the patient might qualify, usually it's a family history of hereditary cancer or heart disease, we will run the prior authorization for the patient and for the doctor. And if it's not insurance based, automatically bills them like through an e-commerce checkout. So the patient pays for the test, and that kicks off a process where we ship them a kit directly to their house. Um, they can do blood as well, but 99.9% of patients just want a convenient saliva-based kit coming to their house. It's got a return mailer through USPS, so if you live on a farm in the middle of nowhere, you can still access our screening. You spit into a cup, fill that up, send it back to our lab. We partnered with Broad Clinical Labs, one of the largest, most prestigious genomics labs in the world. So your return sample goes to Broad. Broad turns that saliva into a raw data file, which then our platform analyzes and delivers a report back to the physician. So it takes 15 to 20 days once we get the sample to our lab. And what we do is what's really unique about our testing versus the status quo testing is that this risk is on a continuum. It's not like you have risk or not. And status quo screening usually says this genetic mutation is pathogenic or likely pathogenic, but it doesn't really give you that much information. Like, what does it really mean? And so, what we try to do is put this genetic risk through these polygenic risk scores on a continuum. So you might have a relative risk of 2.5 times the population average, and we know what the lifetime risk of that condition is. And so we give you that kind of severity metric so you can see are you at increased risk or not? And if so, how much? And patients with other clinical risk factors like hypertension or prediabetes, if the test indicates they're not at our threshold for increased risk, but they have some of these other factors, the doctor can have that shared discussion with the patient and treat the patient possibly like they are at increased risk.
Hmm.
So it gives the doctor a lot of information to treat the patient, and for the patient, we're seeing it can be very motivating to change their behavior.
Hmm. Hmm. In what way are we kind of changing the way this process has worked historically? So, right, so like how is your process really being able to kind of provide that information in a different way than what patients are historically been able to utilize?
Yeah, so we contextualize the genetic risk against clinical risk factors. For example, if you're at risk for coronary artery disease, we don't just say you're at risk, have a nice day. We not only deliver the relative risk metric, but we show what's the relative risk of being a smoker? What's the relative risk of having hypertension? What's the relative risk of if you had a high BMI? So it, I think, lands a little more clearly that, oh, wow, my genetic risk is 2.1 times. That's the equivalent of me being a smoker. And so some of this can be scary because it's new, and very few people are educated in genomics. And so we try to contextualize that information so it's simple to understand, or I should say
Mm,
more simple to
mhm.
understand
Yeah,
and more
yeah.
relatable.
Totally. And, this is new, right? But genomics, we've been talking about genomics really since the Human Genome Project. We've had companies like 23andMe, precision medicine initiatives, lots of hype around this space. What's kind of different about genomics right now? What's changed to kind of make this the right moment for this type of solution?
I think we're seeing a fascinating milestone or threshold with Moore's law, right? Genomics used to cost millions of dollars to get your DNA sequenced, and now you can have a whole genome sequencing for under $500. And so, for the first time ever, scientists, patients, individuals are able to afford the research or direct purchase of this information.
Mhm.
And with more literature and science comes more evidence that there's clinical and scientific utility to be covered for insurance. But that combined with the rise of the LLMs and a lot of this accessible AI technology, you have very motivated patients who have access to now a enormous amount of genomic information and AI tools. And when you put those together, you're seeing a lot of patients really getting ahead of their appointment saying, okay, well, I have this mutation, this means this, or it's really easy now to analyze data and not rely on the scientists or the research. And so patients really can be empowered to take this matter into their own hands. And the science is getting so strong that you can now, we know that 60% of the patients that have a high polygenic risk score for colorectal cancer are going to have a potentially cancerous polyp, right? And so we know that even what LDL targets would be recommended for a severity of genetic risk. So I think we're finally getting to a point where we can call precision medicine precise, right? It was kind of a nice little buzzword. But now you're seeing very specific uses for the genetic risk.
Mhm.
And
What
you're
what
giving patients a very clear path to go down
Yeah.
in some cases.
Yeah. What is your relationship with the LLMs? I'm curious. I mean, are you kind of hoping to give people a more informed option rather than just throwing all of their information into the LLM and letting them kind of understand it? But working through you guys really provides the additional layer of context information. Kind of talk to me about how you guys sort of operate within the LLM universe.
Yeah, so our first platform, the Detect platform, was identifying risk, not using any LLMs. We were doing this before the rise of some of these platforms came out. And to do that, you're looking at genome-wide association studies that, the UK Biobank or the All of Us program, or a lot of these hospitals have proprietary programs that link the variants to a phenotype, coronary artery disease, type 2 diabetes. Um, there may or may not, can't confirm, can't deny, be some platforms and tools that we're building that could help serve as co-pilots for both the provider or the patient to maybe or maybe not smart prompt some of the genetic and clinical data into these tools so that it's very narrowly focused to an outcome.
Mm.
And
Mhm.
it could be what's the right literature that I need to reference to make a clinical recommendation if you're a doctor, because there's a lot of literature out there. And for the patient, education on what may be the right questions to ask my doctor, given kind of this mix of variables, both
Mhm.
the genetic risk and clinical factors. So
Yeah.
I
Great.
think I think we're good. It's a great time to be in this business, and the space is moving at lightning speed, and you're really able to unlock these insights for patients. That we have a patient. She had a STEMI. That's 100% blocked heart attack, otherwise known as a widowmaker, and she was 47. and she just happens to be the president of UPS. And this is a public story. You can go see her case study on our website. She was also on the Today Show. But Sarah Castellan was fortunate enough to take our test after she had her heart attack, and this was the first genetic insight that led her to believe she had a predisposition to heart disease. She had normal cholesterol, she had no calcium on her heart months before her heart attack. And if she would have known this information, a year or two prior, maybe she would have gone down a different path to identify um, that, her arteries were blocked. And
Mm,
so we, have seen a lot of cases where people are getting our test after they have an event to understand if they have genomics. But we've also had some unfortunate cases where we've predicted some things that have actually come true very shortly after.
mm,
And some of those have been cases where the patients lived and some not so much.
mm,
So we really want to make the whole public aware that this technology is available
mhm,
and it's not millions of dollars. It's not thousands of dollars. It's accessible. And our job now is to educate the doctors, make them understand the science behind it and why it's valid, help them understand the utility and what you could do with it, and do the same with patients.
mhm. Yeah.
And I think we're in a day and age where the patients are going to run faster than a lot of the providers.
Yeah. Yeah, I mean, the testing is one piece of it, and then acting right on that result is another. How are you guys working on that piece, on closing the loop between the result and then the clinical decision? Where does the your platform's role kind of begin and end there?
Actually, I think that's the most important question you've asked, Jim. And I think the science is actually relatively easy compared to the implementation. That is where we've probably spent 90% of our resources since inception. We hired genetic counselors not to see patients, but just to write content. We partnered with Endeavor Health, leading precision medicine hospital system, and engaged deeply with specialists in cardiology, endocrinology, medical genetics, oncology, primary care to really understand how best to develop the reporting to make it legible, uh, to develop care paths and recommendations that would make sense because there aren't or haven't been a lot of guidelines for what do you do with this test yet. And, so whenever you have a situation where there's, this really good science has a lot of statistical utility, but there's no guideline and framework for what specifically I'm supposed to do as a doctor, you really have to rely on the progressive specialists and physicians that are willing to figure it out
Mhm.
and make those judgment calls on what they feel comfortable doing.
Yeah. Yeah. Yeah, the healthcare industry, can move sometimes a bit slower than than a tech startup, right? Physicians are busy, change is hard, of course. And how are you kind of working with that incumbent space, actually getting doctors to integrate Genomic MD into their practice? How has that been cracking that nut?
Well, Jim, we have to be invisible. We have to be frictionless. Doctors are so busy, burnout, have such little resources for new information, new tests. We have to be able to, our platform allows them to order in under a minute. They don't have to run any prior authorizations for insurance. We built a tremendous amount of automation from order to result so that we can scale to thousands of tests incrementally a month without any increase in burden on the physician. And um, we try to make it as simple as possible. It's a complicated problem, and we got a lot of work to do on that end. But embedding it into their workflow, doing a lot of education, and I think we're going to see a rise of agentic infrastructure that's going to help uh, a lot of the tasks that may be burdensome in terms of time constraints. I think there's some opportunities for solutions in that area that help the use, deployment, activation, quantification of the genomics, what this means, how to use it, and the outreach to the patient. Because ultimately, it's great, but if you can't get blood pressure under control and you can't convince somebody to come in for the colonoscopy, right? You're not going to prevent, detection of diseases. You're not going to prevent and detect these diseases from happening. So it's not just the identification that there's risk. There has to be activation.
Right. Totally. Totally. So, Jason, what's next? You teased a little bit of something that may be coming down the road, but I'm curious, over the next year or so, what are some new bets you guys are making? What are you excited about? Some milestones down the road?
So about a month ago, the new cholesterol guidelines changed to include, for the first time ever, a polygenic risk score for coronary artery disease in cases where the prevent score is at or greater than 3%, right? So that's borderline ASCVD risk. So that opens up guideline-based screening to roughly 20 million Americans now. And, we think that there's enough evidence for other breast cancer, prostate cancer, maybe colorectal cancer to change as well. So on one hand, we're pioneering in the space before the guidelines are there, and guidelines are coming. So I think the medical community is starting to recognize that risk is on a continuum, that the non-coding region offers a lot of clues into predicting disease. And I think, where we're really focused on is you have this genomic data. What about all the clinical data? How do you put it all together and automate and provide a lot of support for the physician to make very quick decisions? So bringing that data to light to them, allowing them to use AI and access the information. So they're not clicking in 25 places. They're not logging into 4 portals. The more we can make ourselves frictionless and invisible and give them access to these tools, I think the more we can expect that to be adopted. And so we're very focused on not only detection, but amplify and activate, amplify that genetic data with other clinical data, and then activate, making sure that the outreach to the patient is very personalized so that they know exactly what to do with this information.
Awesome.
I also
Cool.
think there's going to be a rise in consumer tools around this information. And
Right.
the more you can kind of create that infinity loop of provider recommending the patient, but also making it accessible so the patient can bring this to their doctor. So if we can complete that loop, I think we're going to be in good shape. The holy grail is to connect claims, clinical data, and omics data so that you can build much more advanced prediction models for health systems, for employers, for plans, so that you can accurately predict which patients, which employees, which cohorts are going to progress to disease. And if you can do that, you can develop programs and plans to prevent that, which ultimately lowers costs and
Awesome.
improves patient outcomes and improves health span. And that's the goal here.
Awesome. Awesome. Well, Jason, thank you so much for joining us today. We at TechNexus have been connecting corporates and startups, building better relationships, and backing startups that are really transforming and reinventing industries. And certainly, you guys are doing just that at GenomicMD. So, Jason, thanks so much for being a part of the conversation today. It was great to chat.
Thank you, Jim. Have a great day.